Navneet, Dr. Ashwin and Ravi. Bhumi,
Hello, sir.
you're there?
Yes, sir. Yes, sir.
Okay. Navneet, Ashwin,
Yes, sir.
you want to check
Joining from my computer so that I can share the screen.
Yeah, you can. And can you just put a word to
Ravi, sir?
Dr. Imon, yeah, because we
I
have
will,
2
I will.
minutes. Yeah,
Yeah, I'll just check with him, sir. Yeah.
Ashwin.
So Ravi sir is joining in a minute. Yeah.
Yeah, no, but we are 7 o'clock. Now we have to start the program.
Yeah, we will
So
start, sir. Yes.
what we'll do is we'll get started and then. So
Yes,
good
sir, we'll
evening,
start, sir.
everyone. Welcome to today's smart learning class on the theme of carcinoma prostate, and I have a great privilege in introducing the two faculty who are board members of Indian School of Urology and USI. To all of you, Dr. Ravi Mohan Movduru and Dr. Ashwin Tamankar. Dr. Ravi Mohan is taking some time to join, and meanwhile, I'll introduce Dr. Ashwin. Dr. Ashwin is at present a uro-oncologist attached to Apollo Cancer Hospital, Navi Mumbai. He has done his MCH urology from Sion Hospital, Mumbai, and after that, he has a keen interest in uro-oncology, and he pursued 1 year extensive training in Tata Memorial Hospital, Mumbai, and then followed by Verticuti Foundation Robotic Uro-Oncology Fellowship in Max Hospital. After that, he has gone to accredited fellowship in uro-oncology under Royal College of Surgeons of England and BOSS at Leicester. And there he had extensive exposure in uro-oncology procedures, both open as well as robotic procedures. And Dr. Ashwin is practicing extensively uro-oncology and has a keen interest in research as well as a passion in teaching. He has many honors and awards to his credit. He has GM Pharke Traveling Fellowship, Sridhara Memorial Prize, Dr. Bridgeport Kishore Patna Prize of USA Got Talent Prize, Shri K. Subramanian Memorial Award, and Dr. A.V. Baligan Memorial Prize. And with this, I welcome Dr. Ashwin Tamankar to this program. And now I'll have a pleasure in introducing to you all Dr. Ravi Mohan. I think Ravi Mohan would have joined. Ravi Mohan, are you there?
He's joined, sir.
Yes,
He's with
sir.
us.
Yes, sir. Hello, sir.
Yeah, Ravi Mohan, you all will be knowing. He's a professor in the Department of Urology at PGI Chandigarh. And he has done his MCH from PGI and then worked as a senior resident, senior research associate, teaching faculty and different position, assistant professor associate, and now he is currently professor. Many international and national awards to his credit, international being the Japanese Urology Association Fellowship, European Urology Scholarship, AUA Chakrabarti Fellowship, and the national awards is USA Member Travel Fellowship and Best Reviewer in Indian Urology in 2020. With this, I welcome Dr. Ravi Mohan to this program. And dear residents, this topic today is intentionally kept in the mind that those candidates who are going for the exam or those who are in the year, the carcinoma prostate is a very important topic. But it's a so vast topic, it's very difficult to cover in one class. So our faculty has split this topic into localized and locally advanced for today, and probably at some time later we'll have a metastatic cancer prostate in the later smart learning class. And today's faculty have prepared this topic in a way that they'll be taking to the journey as a case discussion. So they have prepared the case. We'll be talking the various ways of evaluating this patient, the various type of biopsy, the evaluation strategy in both the localized or it's a locally advanced. They'll be this finalizing the discussion with the carry home messages, especially meant for the residents who are preparing for the exam. I request all of you to be a little active, and probably you can post your doubts and questions and queries in the chat box, which we'll be taking at the end of both the case discussions. With this, I welcome Dr. Ashwin and Dr. Ravi Mohan. Who is starting with the case? Both of you together?
Yeah, so
Ashwin,
we'll go in sync.
Okay. Over to you.
Okay, thank you, sir. So, good evening, everyone. We have a good attendance. So let's keep this session interactive for like 1.5 hours. What me and Ravi sir thought was we'll go through 2 case scenarios, which will include the topics which we are deciding to discuss today. So I'll start with the first case. Ravi sir, should I?
Yes, Ashwin, please.
Yeah. So first case, 60-year-old gentleman. This is not going to be like a vibe or something, but we will try and discuss amongst ourselves, and that would just keep on rolling the ball. In case of any doubts, you can please drop the questions in chat box, and we'll in last 10 minutes we'll try and address those questions. 10-15 minutes. So first case, 60-year-old gentleman had minimal LUTS. He essentially went for a health checkup. So he discussed about there was a discussion about the PSA test by the health checkup guys, and he opted in for it. So I'm just trying to unshare so that sir will be able to share a PPT on PSA screening. Yeah. To you, sir.
Yeah. Thank you, Ashwin. And as you mentioned that it's more of an interactive session. So I'll be discussing in brief about the technical nuances in PSA screening. What are the benefits versus the harm? So I think I'll give it a formal lecture, but as the questions keep on coming on, keep adding, and you can interrupt Ashwin as and when required if I'm just crossing the line. So prostate cancer screening, why it is controversial? We all know that it's a very common disease, but it doesn't affect survival. So that's one reason why it is controversial. Screening has increased the number of cases, but it has little changed the benefit. It has little caused any extra benefit in survival. So that's another reason. And then treatment options have significant side effects. So it's not just it is screen and you don't treat. Again, it's both psychological, and when you treat, there are a lot of side effects. We know that more people die with it than of it. That's a famous saying for prostate cancer, and this table also shows that. So just remember that we should not really jump onto just screening for prostate cancer as happens in India, that every odd test a patient comes with a health checkup and he gets a PSA done without even understanding what are the implications of it. Now, these are the stats of prostate cancer. It's not the most common cause of death, although it's the most common cause of caseload of new cancer cases. Then even the serious death, they occur at 80 years, whereas with respect to breast cancer, lung cancer, other cancers, the serious deaths are much earlier. So prostate cancer is causing death at the very later stage. And at low risk, if you detect, mostly the screen detected ones would be the low risk. They would not show any deaths up to 10 to 15 years of diagnosis. So having said that, lifetime risk of developing a cancer is 10%, but like developing a death because of cancer is only 2 to 3%. But what happened in the West, and what we're following right now as such from what happened in the West, is that PSA, once it was approved, there was a sharp rise in the number of cases, and it became the most common cancer. Surpassed all of the cancers across the globe till 1992. And then people started looking in that, are we really causing any benefit? And then with that questioning, PSA, the screening, questioning of the screening, there was decrease in caseload. And but having said that, because it is detected in so huge numbers, it happens to be the second leading cancer killer in men. So it's not that it is not a cancer at all. There are certain bad ones, and we need to discriminate which are the bad ones from the good ones. So, and if by screening we are able to detect right at the beginning, then probably we have served it. So that is where the need of the hour is. Now let us see what is the status of screening. As of now, the various guidelines, they would say it's a shared decision making. So it should not be that you just say that we get a PSA done. It has to be shared decision making. So we have to discuss, and as the case presented here, the gentleman was discussed about the benefits and harms of prostate cancer screening. That patient has to understand if the PSA is elevated, what all test or what is the pathway he's going to follow. The PSA is normal, what is the pathway he's going to follow. And especially has to be in that age group of 50 to 69, and not that you start getting PSA of a 40-year-old gentleman with LUTS, or you start getting PSA of an 80-year-old gentleman with LUTS. So just understand, just remember this as we go along. Then US Prevention Task Force actually changed the grading. There was a huge hue and cry about it. that they changed, they gave a grade C recommendation from a grade B or grade A recommendation to grade C for screening between 55 to 69, and for grade for beyond 70 years, they just say that it should be grade D recommendation. That is there is no need for recommendation, no need for PSA screening. And for 55 to 69, again, it is that patient has to understand the potential benefits and harms, even for harms of biopsy, which we failed to explain. So it has to be detailed out before you decide on to before you advise them on PSA screening. So 55 to 69, discuss it. 70-year or older, don't just do it. Now, what we do in India is opportunity screening. It is not the organized screening as was being showed in the West. It is an opportunistic screening that a patient walks to you with LUTS, and in that process, you decide to get a PSA done, or you do an examination, DI digital examination. You find something suspicious, you get a PSA done. So that is a kind of that. Although that's not a screening, but it is still falls under the domain of opportunistic screening. Now, screening, it is not screening may reduce the risk of prostate cancer, but at what cost? You would have to treat the active treatment is associated with a lot of sexual and urinary difficulties. Although if you see this graph, you can see that the screening group has better survival than as compared to less risk of death than as compared to non-screened population. But then at what cost? At 11 years follow-up, you'll have to screen 1,055 men, detect 37 cancers, and to prevent one all-cause mortality because of one prostate-specific mortality, and all-cause mortality remains the same. So really should we get into this jargon? Again, the amount of harms radical prostatectomy has as compared to observation, the harms with erectile dysfunction, with urinary incontinence, even radiotherapy has its own negative effects on both sexual and sexual function. So in conclusion, what this tells you is that treatment of prostate cancer has a good amount of associated with very strong evidence of urinary and erectile dysfunction, 20 to 30 times extra more than what without that. Radiation treatment has at least 17% extra risk of having erectile dysfunction and bowel dysfunction. And to prevent one prostate cancer death, you'll have to screen 1,000 men who are to be followed for 10 to 15 years. Now, there are a few more questions which need to be addressed. What is the normal PSA? In India, probably we don't even have what is the normal values of PSA. And there are certain papers from India where they say that our PSA cutoff should be a little higher than what in the West. But let us see the Western literature, because we have robust data for that. The median for man for between up to 50 is only 0.7. Between 50 to 60 is 0.9. A rise of more than 0.75 is worrisome. And a man who has a PS at 60 and has a PSA less than 1 is rarely ever would have a serious cancer. So you actually should not get on screening him. We have patients in the OPD who would have PSA of less than 1 at 60, and they keep on doing PSA every year. It's an idea, okay, I should not die of prostate cancer. It would never happen. So this is again a table which shows what is the PSA level with respect to different ages. This is from the Campbell, so you can always refer it back. In PCPT trial, the famous trial, I would recommend all the residents when they want to read about prostate cancer, they must read about this PCPT trial, because this trial addresses many other domains of prostate cancer, early prostate cancer management, that diagnosis. So when the PSA was less than 4, we missed about 14% of cancers. So not that less than 4 means no cancer, at least 15% of cancers would still be there. Between 4 to 10, there was a risk of cancer having, when the PSA is less than 4, there is a 15% chance that you might have a cancer and not detected. When PSA is between 4 to 10, there is 30 to 35% of chance that one might have a prostate cancer. When the PSA is more than 10, then there is a 67% chance. So with that cutoff, what traditionally is followed is a PSA cutoff of 4 to 10, or more than 4. Now, we also know that when the PSA goes beyond 10, the cure rate also falls. So as we go on with the case discussion, it will be evident in the cases. Now, so that's why NCCN guidelines says that when the PSA is for between 45 to 75 years of age, the PSA is less than 1, repeat at 2 to 4 years interval. Don't repeat every year in the interval, because the PSA is less than 1 in this age group. Even a 2 years interval of screening is sufficient. For PSA between 1 to 3, repeat 1 to 2 years. And for PSA more than 3 or a suspicious DRE, consider biopsy. So that's what NCCN says. And beyond 75, really, and the patient is healthy, then only you consider evaluating PSA when it is more than, considering biopsy when the PSA is more than 4. Otherwise, you actually should not do it. Now, to improve the sensitivity, there are certain more biomarkers. Free PSA, which is the unbound form of PSA, in prostate cancer is typically decreases because the majority of the PSA which is detected will be in the bound form. So free PSA less than 10 with a PSA in an intermediate range of 4 to 10 or a suspicious range would have some implication in deciding for a biopsy. Now, prostate health index, again, an index where just remember the value when it is more than 35, it is significant. The 4K score when it is more than 7.5, it is significant. And then there is a new after negative biopsy and elevated PSA, there is something called confirm MDX, which is a genomic analysis of the tissue, which would, if it shows some particular group of genes and it gives automatic scoring, that is when you would say that PCA score of more than 35, that is when you would label it as a likelihood of a prostate malignancy. And then obviously you'll have multiparametric MRI, which will come up in the discussion subsequently. Now I'll skip this for want of time. But what is prostate health index? It is PSA, free PSA, and the pre-pro PSA. And when the value is more than the probability of cancer increases when it is beyond 55 to 50%, but beyond 35 is considered a significant value where you should investigate further with respect to biopsy. Now, 4K score is essentially PSA, free PSA, intact PSA, and the HSK, the human calcium PSA. And even the 4K, when it is more than 7.5, the risk of patient having a malignancy or the patient had the risk of developing metastasis increases. So a 4K score is an adjunct to the PSA. It is not a substitute to PSA. Now, there are certain high-risk groups. So race probably not relevant to us, African American and white, but family history. So in a population, the first graph is showing what is the population-based risk factor of developing a malignant of prostate cancer. But if you have first-degree relative, which is a brother, or if a father and a brother has a prostate cancer, or if there are two brothers in a family, or if a father plus two brothers. So the rest of the four graphs are showing how significantly the risk of prostate cancer increases. And it is predominantly all the three types: any cancer, low risk cancer, and high risk cancer. So these are the groups where you must screen them. And there are various cancer risk calculators. So it's easy for you to explain the patient that you use one of these calculators, show them that they have this much of risk, and then that's easy to explain them with respect to guiding them for biopsy. This is how a typical report would look. Now, Indian scenario, as I mentioned, we don't have a serum cutoff values of our own. And there are certain papers from the SGPJ group where they mentioned that a cutoff, our Indian cutoff should be beyond more than 5 or 5.4, where they actually found that for detecting a significant prostate cancer or avoiding unnecessary biopsy. So, friends, to summarize, don't just screen every patient, screen at the right age, between 55 to 64. Always do a shared decision making, that you have to discuss the benefits and harms. Must screen high risk population. Although if you go to NCCN, they say that high risk population should be screened beyond 45, but technically speaking, 50 onwards, you can screen high risk population. You can use added parameters to further supplement the chances that the PSA which is found, is it really going to be significant or not. So I will end the slide here, Ashwin.
So just to add to that, a couple of things. One was how is this 55 magic number, as in from which place is it derived from? That can be a question in the exam. So me and Ravi sir thought that we can keep it more theoretical as well as from practical point of view. We can go as per the questions which can be designed in the exam scenario as well in the practical. So finish was the small subset of the group from the ERSPC trial. Which ERSPC is the only trial which is, or it is one of the important trials which is in favor of screening, which sir has already mentioned. So finish was the group which was subset of patients which were maximally benefited because of PSA screening in long-term follow-up, and those numbers were age-wise 55 to 69, and that's why they have been incorporated by the American Urological Association, and that's why if we see the difference, AUA will say beyond 55 we screen, and European other guidelines will say beyond 50 we screen. That's a little difference. Whichever guideline we stick to, we just have to justify that in the exam. That is what I would say. And sir was mentioning about the number needed to screen and number needed to treat. So a little new data on the ERSPC. This is a data which is published a couple of years back. With the increased number of years, number needed to screen is coming down now, just to prevent one death. So earlier it was 1400 at 9 years. Now at 16 years it is 570. So that itself speaks about the advantages of PSA screening, but obviously it has to be properly discussed with the patient, and number needed to treat is come down from 48 to 18. So to prevent one death of prostate cancer, as of now, with 16 years of ERSPC data, we can have numbers of 570 for screening and 18 for treatment. So that will have some impact. So
yeah, Ashwin, I just want to
yes,
add something
yes,
here, that the resident should also remember that you can go to the previous slide.
Yeah.
The fourth one, yeah, that they must mention that for a 16 years follow-up, that's where the number needed to screen would come down to 570 and 18. At a 9 years, it would actually be 1410. So just understand, the patient has to be kept under follow-up for so many years, or this cohort was kept under follow-up for so many years. And obviously at 16 years, many of them went on to develop prostate cancer, and that's how this number actually came down. You're getting my my point. So the residents
a
have
little
to
larger follow-up is
understand.
required because of the slow biology of the disease. That is what sir is proud.
So as the and probably if you let's say you start a screening at 70 years, then 86 is the year when 16 years follow-up would be there. So then the detection becomes irrelevant. So that's why you just stick to this 55 to 69 as an age group of as an age for the PSA screening. Yeah.
And that is where the maximum advantage as per the finished subset which has been found. The second thing is, so just continuing the case, this gentleman underwent a PSA test along with urine routine. So one important point is always ask for urine routine in addition to PSA, because we would want to rule out infection whenever possible at the time of PSA testing. So PSA was 12, urine routine did not show any infection. Examination is very much important because examiner is going to judge you based on how you mention about the findings. So there was a nodule in the peripheral zone nearly 1 centimeter. You can say you can quantify that by volume or by finger breadth or by centimeters. Approximate size of the prostate was 30 grams, or maybe say you can say grade 1 or grade 2. Median sulcus and lateral sulcus were palpable. Planes were not obliterated. Rectal mucosa was free and anal tone was normal. The urinary scores of this particular patient, IPSS, was 6 out of 35. And sexual function scores also need to be quantified. So these are important 2 scores which you should be embarking in the history taking of a long case of a prostate cancer. So IPSS and SHIM, we are not going in details of those because we are here to discuss about prostate today. And most importantly, the performance status and the comorbidities of the patients. So what next for this particular patient? So I'll try and
Ashwin,
emphasize.
can we answer one question? What are the causes of false elevation of
yes,
prostate?
Sir, please, sir.
PSA?
Yes.
So I think you can start with few and I can add with few. So one is he mentioned DRE, digital rectal examination. If you do a digital rectal examination and get a PSA very next day, you might have a 1.5 times elevated. But if the PSA is, let's say, beyond 10, then these discussion won't come in. Actually, nobody will ask you. But when it is less than 10, they might start questioning, is it a fallaciously elevated? One is an abnormal DRE, other is an infection, which already Ashwin mentioned, that if you have, or a recent sexual encounter that he had ejaculated the previous night or other sex, and you can, and gets a PSA very next day, he might have a fallacious elevation. Ashwin, you can add further.
False reduction, I would just add dutasteride and finasteride. Whenever someone is on those medications, we routinely encounter these scenarios. So the mathematics is to correct it by double amount after it is, if it has been continued for at least beyond 6 months. So corrected, we call it corrected PSA, so that you just have to double it if it is beyond 6 months.
Ashwin, you can make it full screen. This slideshow can be made full screen. Yeah.
Yes, sir. Yes, sir. Sorry. Yeah. Is it better? Yeah.
Yeah.
Yes.
So the next is what would be the next step, because he is an individual who's been picked up on a health screening and PSA is little borderline. Examination shows some suspicion. That is what we are at this point of time. So MRI is generally done before the biopsy. So examiner probably in 2022 examiner would be looking into this. In 2016 or when Sir graduated, or Chawla Sir graduated, that point of time it wasn't in the armamentarium. In my exam days it wasn't into the armamentarium, but in last 2018 and 19 the thing is changed. So probably examiner will expect from all of you that MRI has to be taken into the armamentarium before the biopsy, unless the PSA is in a very high metastatic range, if sir would agree on that. So if the PSA is localized or locally advanced setting, say about 30, 40, 50, I would probably go for an MRI before the biopsy, and you can very well justify that, preferably in a localized or locally advanced setting when you think about the PSA value. So there are 3 papers to justify that, which I'll quickly summarize in front of you. Obviously, I've tried to assimilate abstracts here, but you are most welcome to go back and read those. We're just trying to give you some insight so that it will be like a comprehensive overview, and then you can actually pull out the data yourself, jot it down for yourself, so that it will be easy for you in the examinations. So MP-MRI prostate, we have 3 papers. One is PROMISE study, which told us, so it was a paired validating study. It wasn't a randomized trial, but a paired validating study. One of the important papers coming from UK. The main highlight of that was they obviously compared it is all biopsy naive patients, and template mapping biopsy versus trust biopsy was where the 2 arms after the MRI was done. So what was the inclusion? The inference, MP-MRI triage might allow 27% reduction in the primary biopsies. It helps us to pick up 18% more clinically significant cancers, and helps us to minimize the clinical detection of clinically insignificant cancer. So that is what we are looking at, to minimize the overdiagnosis or over treatment for prostate cancer. So that 2-3 numbers you can remember for exam purposes and maybe theoretical purposes. This can very well come as a question for a role of MRI before the biopsy. So second paper on the similar note, though this paper wasn't actually designed to prove the role of MRI before the biopsy, but the byproduct of the interpretation was MRI scores. As an MRI, if you do before the biopsy, it's always advantageous. So precision was the study group. So I'll come to the conclusion here. What they did was, what they mentioned was, the use of risk assessment of MRI before the biopsy and MRI targeted biopsy was superior to standard transrectal ultrasound guided biopsy in men with clinical risk of prostate cancer who had not undergone a previous biopsy. So all biopsy naive patients. So that was again for a precision trial. And MRI first, it was a prospective multicenter pair diagnostic study. Though again, this paper primarily was done for comparing differences between only or potentially skipping the systemic biopsy and only doing the template mapping biopsies, whether it is beneficial or not. And the conclusion was no. So the paper told us that you have to go ahead with both template mapping biopsy as well as the standard template biopsies of 12 core, and you do an MRI before the biopsy. So essentially, if I can say, role of MRI before the biopsy will be emphasized by these 3 papers, which we have summarized. You can jot it down: PROMISE, precision, and MRI first trial. And that told us that MRI has to be done before the biopsy. So there is very well backing for all of you to now say that I will go for an MRI before the biopsy if you think that the individual or the gentleman as a case in the examination is not in a metastatic range. Should we go further, sir? You want to add something on the MRI, sir?
No, I think you summarized it nicely. I think it's clear.
So I'll just put a EAU this thing, the table. Majority of references I've taken from EAU. So another one point which I wanted to say was, we always get, as a student, we always get confused between which guidelines to follow, and we try and do mix match. So I think just follow one particular guideline and just believe in it, and then stratification, everything you should follow on that particular side, so that there will not be any confusions. So MRI has to be before the biopsy. I'm just reading these 3 lines. When MRI is positive, then targeted and systemic biopsies, and MRI is negative and the index of suspicion is high, then again the biopsy, you can omit the biopsy provided the shared decision making has happened. So again, pyrite score, I'm going to come to the pyrite scoring as the next slide after this. So pyrite score obviously told us, so essentially pyrites will have 4 elements. I'll describe, sir, initially, and then you can add your inputs afterwards if that is. So pyrites will have 4 elements. One is standard T1 weighted image, second is T2 weighted image, the dynamic contrast enhanced image, and ADC and diffusion weighted image. So these are the 4. ADC and DWI are they are a part of one unit always. So it's like a reciprocating image. Whatever which is hyper intense on DWI will have hypo intensity on ADC. So it's like one unit. Essentially, it's little confusing. It's ideally a radiologist's job, but for exam purposes, what you should remember is, firstly, pyrites V2 version is which we follow now. Pyrites will have 4 elements of MRI. It's a functional MRI. T1 and T2 are basic units, and other 2 are the functional elements of the MRI purposes. In peripheral zone, ideally the peripheral zone should be bright white on the T2 image. MRI. So normally we look into the T2 images of the prostate. So it should be a bright white. So it's like a if you appreciate this, it's like a mustache which is nicely seen on white images, the T2 images. Any hypointensity there should inflict into a potential lesion or potential suspicion, I would say. So peripheral zones, you are more relying on DW and ADC, and transition zone is transition zone and central zones, you are going to rely on the T2 images for the pyrites classification. This is very simple. It looks initially confusing, but if you actually look into it, just remember 2-3 things. One is peripheral zone, you go into DWI, ADC, and transition T for T. Transition, you go for T2 images. Everywhere, whenever there is an abnormality, the score goes up. The difference between anything which is larger in size or has extra prostate extension will be straight away labeled as 5. The 3 and 4 difference would be based on, here your peripheral zone, you're using DW and ADC. So you're utilizing contrast imaging for differentiating between 3 and 4. And against to that, in transition zone, you're using T2 baseline image. That's why you're using DWI to differentiate between 3 and 4. And the scores of combined peripheral and transition zones will be assimilated together to give the final scoring of pyrites, or probably they will give it at different zones as different pyrite score. That is what they normally do. A quick line on biparametric versus multiparametric MRI. These days, there is a lot of buzz about biparametric MRI. The reason being, firstly, the contrast doesn't add to a very large extent. That is what they are believing. Secondly, it adds to the cost. It adds to potential toxicities of contrast. We all know that those nephrogenic, what do you say, that nephrogenic systemic fibrosis, fibrosis, and potentially the timing. These are the elements which are added against to no potential excess benefit. If you actually see a conventional pyrites, contrast imaging will only give you one subtle differentiation between 3 and 4 in the peripheral zone. That's why they are trying to omit that dynamic contrast imaging as per the new biparametric scores. Still, probably I would say, I'll take sir's input on this, but still we are doing all 4 we're utilizing all 4 pillars of pyrites as of now in the day-to-day practice. In another 1 or 2 years, we would be getting to biparametric scores eventually and relying only on those, and selectively use contrast only if it is necessary. That is what the policy would be. But I would just take it as an ask sir to give inputs on until here on the MRI.
Ashwin well summarized MRI findings, but I think the residents can actually answer that in the present time. The question would be, should it be a 1.5 Tesla versus a 3 Tesla? So the literature is clear that this pyrite scoring can be based on 1.5 Tesla. You actually need not have a 3 Tesla MRI. So, but higher the better. So they can say 3 Tesla is preferred or 1.5 is sufficient. The second question would be, should we really do a biparametric or multiparametric? When you write on a prescription, you write a multiparametric MRI as a prescription. However, if the MRI radiologist forgets to forgets to mention all the phases, but he is mentioning parade based on biparametric images, it should be acceptable, except that you should have the dynamic contrast enhancement only when it is a parade 3 lesion. Then if you have multiple differential lesions, then the reporting has to become in a way that the highest lesion of parade should be mentioned first, followed by the lowest, and each lesion needs to be individually graded and cannot be just like you have one parade 5 should make it. Why it is important is that because apart from presence of malignancy, it also the parade has also been correlated with the grade of a significant high risk cancer. So it is essential also to know that if there is one parade 4 and one parade 5, that it should be mentioned specifically. These are the things, Ashwin. Over to you.
Yeah, and just one quick packing or summary of doing an MRI before the biopsy. Firstly, like I said, these 3 papers you can always quote. Secondly, it will give you a naive picture of the prostate before the biopsy has been done. And secondly, it will help you for a planning, because if you commit a biopsy and then detect a prostate cancer, we have to wait at least for 4 weeks for getting an MRI. That's another drawback of not doing MRI earlier. So all 3-4 reasons you can very well give as a backing. And one important thing is, whenever you're saying or requesting MRI, please clearly put it as MP-MRI prostate plus pelvis. It has to be covering the pelvis, because you would also want to know the node. So examiner need not go and ask or keep digging answers from you that do you actually want to cover pelvis as well. It has to be a crystal clear answer. Multiparametric MRI prostate plus pelvis I would need for this patient, and then depending upon the findings, I'll go for a biopsy. So let's continue the case. This individual had a MRI done, which was again MP-MRI prostate with pelvis. Pirates 5 lesion in the left peripheral zone, which is mentioned here. If you not nicely seen, but these are white peripheral zones. It's a coronal axis. There is a hypointensity here near the capsule. Capsule was fairly maintained, so they have labeled it as organ confined. It is sometimes difficult, but you probably in the exam scenario, it will not be like a confusing scenario. They will either give you a proper locally advanced or a localized case. So this case was an organ confined disease. Seminal vesicles were normal. There were no nodes. The rectal planes were normal. The neurovascular bundles were normal. So all 5 or 6 findings we are looking at in the prostate plus possible lesion. So this individual had only 1 lesion on the MRI. Sir, anything to be seen on the MRI comment from your end, apart from what we discussed?
No, so it looks fine. The only thing is that if the resident in exam mentions the parade score, he should be able to read and point out, not that so it's always sometimes if the residents are not very sure what they're looking at, they can always seek the radiologist help, that they would seek a radiologist, and they can tell that in exam also, that they would discuss with the radiologist about the specific lesions and the other things, and as you mentioned, that involvement of seminal vesicle and the presence of nodes. Sometimes you might see a neurovascular bundle, a nice neurovascular bundle in the axial cuts, and and involvement or extension into that may also come as an added finding.
So this individual underwent a biopsy. I'll come to the biopsy findings later. Let's talk about biopsy a bit. I have just incorporated few slides in the same PPT. So there is a lot of discussion on transperineal biopsies happening these days, and as examinees in year 2022, you should be aware of this particular fact. So I'll just summarize few things. Meta-analysis from important 1300 patients and few randomized trials also told us that transperineal has less of infections than transrectal. 8 RCTs showing rectal. So if you're using transrectal biopsy, you also should be emphasizing povidone iodine enema before the biopsy, because in the randomized scenario, it is shown to have reduced infection. You also need to cover the antibiotics, so that antibiotic prophylaxis can be based on the rectal swab or as per your antibiotic policy in the institute. The transperineal in a given scenario scores over transrectal in terms of infective complications, and it scores equally in terms of the detection rates. Transperineal biopsy, if I can talk about it I'll come to that in the next slide. So the guidelines would say perform biopsies of transperineal. So this is completely changed now in 2022, though we are not there in India, especially in the exam scenario. We may not be in a position to talk about transperineal, but you should be completely thorough and aware, and examiner should be knowing that the fact that transperineal is the way forward eventually. But as of now in India, because of certain limitations, we are continuing transrectal. Use of surgical disinfection. For transperineal, you just use surgical disinfection of the skin. For transrectal, povidone iodine enema is must. Even if you do not practice in your own center, it's a good way to mention this, or maybe just stick to what you do in your standard practice in the exam scenario. About the antibiotic, again, there'll be a controversy. I completely agree to this fact that even till date, many of us are using fluoroquinolones as the prophylaxis in majority of the centers, and EAU has given a strict negative guidelines against it. So probably the best way to bail out from in the examination is you tell that it's an antibiotic policy which is described in, or which is established in my institute as of now. We haven't changed it, but I am aware of the fact that EAU has given some negative recommendation against fluoroquinolones. That is what I would say. We'll take inputs from Ravi sir in the end on this, because he's been a regular examiner, and even Chawla sir. So fluoroquinolone is a negative recommendation now as per the clear mention from the EAU guidelines. So antibiotic targeted prophylaxis in a transrectal biopsy is either rectal swab or stool culture, though we do not do it in regular practice, but that can very well be quoted. And for transperineal, you give only 1 dose of antibiotic as a part of antibiotic prophylaxis. All the cohorts should be sent separately. All of us know that. I may not be discussing how we do the biopsy. We kept it more theoretical. We all know how we do the biopsies. I'm discussing a bit on the transperineal biopsies. So this was a paper which I have also summarized. So transperineal biopsies score in terms of infective complications, majority, less of sepsis, less of infections, and less of cost because of that. And that's why the AU guidelines have assimilated this into the armamentarium. I think that's it, sir. Do you want to add? I have not gone to the theory of how to do the biopsy, because we need to cover other topics also.
Yeah. So regarding antibiotics, I think one of the reasons why EU recommends against it is to prevent antibiotic resistance, because for their fluoroquinolones is one good drug. But for India, I think most of our bugs are resistant to the standard, the low generation antibiotics. So even if the resident says that he would be using fluoroquinolone, and that's a standard practice. So exam, I think more important is to stick to whatever you practice in your institute, and then you have internals who justify what you say. If you just quote theory and but which is not practiced in your institute, examiner might look surprised, because he knows that what is happening in India. So that's where, otherwise, as Dr. Ashwin mentioned, that you must be aware of the guidelines. Some examiner might actually want to screw you in theory, so he might just ask you specifically, what do you have any idea about fluoroquinolones used in prophylaxis. But for exams, if you justify yourself saying that this is what is the standard practice in our institute, you should be through. Chawla sir, any comments on that?
Sir, can you use your headphones? After you took out the headphones, your voice was diminished a little.
If that's okay. It's fine. Ravimon is doing fine.
Right, sir. So should we go ahead?
Yeah, Ashwin.
Right. Yes. So examiner will obviously keep asking
one small thing, Ashwin.
Yeah.
Another problem of transperineal biopsy is need for special gadgets, which may not be. We also did not discuss about MRI guided biopsy, TRUST guided biopsy versus transperineal biopsy. Do you want to add anything on that?
I think in the exam scenarios, we stick to standard template transrectal biopsies. So 12 cores at least, all cores separately, and we target 1 or 2 extra cores from a target lesion, if you can appreciate that in the this thing. Local anesthesia is a must tool before the biopsy. We give it at the angles near the rectoprostatic angles, near the tip of the seminal vesicles, where the neurovascular bundles actually run through. They used to call it Mount Everest sign. I don't know how it is described, but theoretically it is called as Mount Everest sign. When we imbibe the local anesthetic in that, it pushes the fascia, the denonvillous fascia. And I still want to add to this. Yeah.
No, perfect.
Okay, so that is how it is described, and we give local anesthesia on both sides of the prostate and then hit the biopsy. That is what we normally do, right? So examiner will obviously ask about the next steps. So always remember one important question, not just in prostate, but any long case scenario, that have we completed the workup of this patient before jumping into the plans? Sometimes in a rush of tempo, we probably immediately jump into the discussion of treatment options, but always ask this question before that particular question, whether the workup is completed. So for prostate, the workup is obviously either twofold. It's either an MDP bone scan or F18 bone scan. But always remember that if you are saying bone scan, then you should add CT scan of the abdomen to rule out pelvic to rule out a retroperitoneal lymphadenopathy. So either a combination of bone scan with CT scan of the abdomen, or you can always say if the PSMA PET scan is available, I would want to utilize it. Sir, what is the take currently as an examiner in 2022? Is it acceptable?
Yes, absolutely. Because the EAU guideline also says that it is one of the accepted investigations. It's not.
So your voice is little low. I'm so sorry.
Okay. Let me use another. Is it better now?
Much better. Yeah.
Yeah. So I would say absolutely it is justified in 2022 to say PSMA PET as a part of diagnostic workup, because even in EAU it is not as bad it was in the past. Now EAU says that it's one of the preferred modalities of investigation. So if the examiner is little you might have some examiners who were trained 30-40 years back, and they might start questioning why not just a CT and bone scan. So you can say yes, that is one arm, or you get a PSMA PET alternatively. Yeah.
Right. So you should be knowing the theoretical aspects of PSMA PET, how it works, why it is specific, so that we are not going in details of it. You should read about it. But per node specificity and sensitivity, and per lesion or the bone lesion sensitivity and specificity of PSMA PET is much superior. On multiple studies, the specificities I have encountered to the range of beyond 90%. So that you have to remember, and that you can always quote in the number in the figures. For the nodal sensitivity, again, compared to the MRI, PSMA PET scan will have some better specificity or similar specificity, but little better predictive values. So as compared for this is for nodal staging. If your positive predictive value and negative predictive value is little better, sensitivity is little better, specificity is similar. So you can very well say that PSMA PET scan will have some definite advantage for nodal staging as well as for distant staging. One important thing is sometimes you get false negative PSMA PETs. Of late, we are getting activity of PSMA in RCCs as well as meningiomas, if the examiner just wants to quickly ask that question to you. So some false negatives which we encounter, there is no logical reason to it, but we get it on certain occasions, especially meningiomas will light up. Sir, anything on the PET?
Another thing is when they do a PSMA PET, they must ensure that the bladder should be empty, because the examiner might just say the patient goes on a full bladder. So in the full bladder, because the radiotraces are coming into the bladder, the prostate will be difficult to see. So typically when they do or the pelvic nodes will be difficult to see. So typically when a PSMA PET is done, the bladder must remain empty.
And it is a nuclear physicist's job to ask the patient to pee and come back if the bladder is full. Another one important line here, it's good that we are interacting. So there are two types of PSMA PET scans which people utilize. Check in your institute. Our standard nomenclature or standard impression in our mind was gallium PSMA, but these days it's been replaced by F18 PSMAs everywhere, majority of the centers. The reason being, gallium will be excreted in the urine, and what will happen is what Sir said. If the bladder is full, you will have some activity as a background in the urine, which will get superimposed with the prostate, and you will be clueless. Especially in a post TURP scenario, you will face a lot of challenges, because that fossa will also get delineated with the urine coming there and lighting up. So what's the advantage of F18 PSMA PET? It is excreted through liver predominantly than kidneys. Against to that, gallium is excreted through the kidneys. That's why it creates problems. So majority centers now have replaced this to F18 PSMA, but please theoretically read about it. If you actually want to impress an examiner, worth saying I would go for F18 PSMA PETs, and that will tell examiner that you know something like F18 PSMA exists. So that is one important thing which you should be reading about. Should we go for the sir?
Yes, further.
Yeah. So now we have done the staging workup. This patient had minor activity on the left side, similar location of the lesion, no other nodes in the pelvis, no other lesion in the entire body spectrum. So he was non-metastatic and N0. So again, do not immediately jump into the conclusions about the treatment. Here the examiner is going to ask you, so doctor, how do you want to treat this patient? So always justify your answer. Tell the examiner, sir, I would want to stratify this individual at this point of time because I've done the workup which is complete, and based on the workup, this individual falls into an intermediate risk stratification as per the AU risk scoring. Whichever you want to follow, you follow and quote it in the examination. Examiner would be fine with it. Even if you want to go for NCCN scoring from very low risk to very high risk, it is fine. EAU is much simpler and it is easier and user friendly for you to quote in the examination for treatment plans. So essentially it is either localized or locally advanced, and localized will be low risk, intermediate, high risk. I'm not going in details. It's wide in front of you. Please read through that. so that, but there should be crystal clear impression on the risk stratification amongst students understanding before you make the plan for the patient. So you tell this to the patient, to tell this to the examiner, sir, this individual falls into an intermediate risk localized prostate cancer. So he would have following options. That is what you would say in the examination. So obviously, though the active surveillance is not the right option for this, but I've just enumerated a few options. So now we are moving towards a discussion of a treatment of a localized prostate cancer. So I'll go through few slides, sir, first on the surveillance and the treatment aspects, and then you'll keep adding things. Okay. So a nice table which I actually found in EAU. This wasn't there at my point of time in like 2-3 years back. So nice addition between the surveillance and the watchful waiting. This is a very favorite question of the examiner. So most important difference is surveillance is given for a patient who deserves the definitive treatment, and you're potentially trying to prevent over treatment at this point of time because of the acceptable or a low risk biology of the disease. Watchful waiting is generally done for patients who are not the good candidates for a definitive therapy because of either fitness or age, and you are just trying to palliate the symptom of a patient by treating at that point of time whenever it is required. Nice summary which is mentioned here. Please go through that properly. Years of expectancy is an important determinant between the
two
and the watchful waiting. Yes. The next slide. Sorry, it's not moving. Yeah. So a summary of papers which back the active surveillance. So 10-year OS and 10-year cancer specific survivals are quite high. So you should be knowing about basic criteria of, so little bit of discussion on the active surveillance. First of all, the patient, simply stating, it should be a low risk patient as per the EAU if you're following, or very low risk or low risk as per the NCCN if you're following. The earlier criteria of Epstein, which is generally known to all, and probably examiners would agree on that as well, as far as my knowledge goes. So in an exam scenario, if the patient is strictly following a criteria as per the Epstein score, I would probably recommend active surveillance as an option. If it is beyond the Epstein's criteria, I would probably say he would need a definitive therapy, though the active surveillance discussion would be done with the patient, but he may not be the rightmost candidate. So Epstein criteria is right here in front of us, which is like similar to what very low risk individual for the as per the NCCN is. So only 1 or 2 cores positive. So less than 3 cores, that is what they say. So 1 or 2 only positive, none core beyond 50% involvement, PSA density of less than 15, less than 0.15. Yeah. So this was the strict Epstein criteria, which was considered for active surveillance eligibility. But there are certain other scoring systems for evaluating the surveillance feasibility, DMICO or CAPRA, or based on the imaging also people have gone to the level of active surveillance eligibility. Probably for exam purposes, Epstein serves better. Sir, do you agree on this? Or
yeah, Epstein or DMICO both should be equally active, because DMICO is very easily, it's one of the very easy criteria scoring system. So even if they say DMICO is fine, but then when they actually mention active surveillance, Epstein should be the one, because that is how the studies were designed.
Yeah. So any number of more than 3 number of cores, any score which is beyond, which is 7 plus beyond, it should be Gleason 6+6. So anything which is intermediate risk and beyond generally should be given a definitive treatment option. But you should be aware what active surveillance means. That's why we have put these slides here. One paper, I don't know whether there are many papers from active surveillance from India, but one small paper which I was co-authored. So there is an upstaging and upgrading which happens in India. Just in case if you want to read through that, you should be aware of the fact. Though there is no robust data for this in India, but active surveillance, we have little high risk disease in India. The ASCO NCCN nice guidance. So this slide I have put for majority follow, because if we are actually discussing about active surveillance, we should be knowing the next steps as well. So the next steps would involve repeat PSA and examination. So examinations are always mentioned annually on majority of the scenario, and PSAs are 3 to 6 monthly. If you actually see the EAU guideline, it would say not sooner than 6 months at least. So PSA, the next evaluation will be at approximately 6 months by a repeat examination and a PSA. One reclassification biopsy is a term which they used to use conventionally, has to be done, and repeat imaging has to be done for initial first consideration. Why so? Because reclassification biopsy will probably pick up the upgradation which is supposed to happen if it is if it is supposed to happen when the treatment plan will be converted from surveillance to definitive treatment. So you should always know the fact of reclassification biopsy. It's not that aaj apne active surveillance you have committed for active surveillance and then you're not following that patient with the biopsy. So one reclassification biopsy, if that biopsy concords on the same lines as of your initial biopsy, then your definitive plan of active surveillance continues, and then you may not need biopsies every now and then. That can be tailored based on the PSA examination or SOS MRI findings. So am I right in saying this?
Yes, yes, absolutely. But
Right.
the patient has to be explained that they need one biopsy after during the follow-up, or at least within a year before we go on to only image-based follow-up. Absolutely.
That is a must biopsy. It is called as reclassification biopsy. So for the active surveillance, obviously these are three important papers which you should be knowing, because examiner would want to, you to quote these papers during the Viva as well. So SPCG4, Scandinavian Prostate Cancer Group. So radical prostatectomy versus watchful waiting. I'll skip 2 slides, go further and come back again. So EAU has summarized these papers nicely. If you see these initial 2 papers, so SPCG and Pivot, they are pre-PSA and early PSA era. So the recruitments were quite early times of PSA screening. PSA actually came into picture in 87 and 1992, if I'm not wrong, they started utilizing, and that's why there was a cull effect. That is also another question. There was a increase in the diagnosis of prostate cancer that is called as cull effect in year 1992 or somewhere or other. So I've forgotten about it, but you should know what
1996.
It's 1996 because of the PSA. So the pre-PSA era and PSA era. So these two were the SPCG and Pivot, and Protect was early PSA screening era. So only Protect had all those screen detected population or screen evaluated population. And this is a summary from EAU. So this is an authentic summary. So I'll go through these 3 papers quickly. What SPCG told us that extended follow-up. So they had long-term follow-ups of 23. This is a 23-year follow-up, and the next slide is 29 years follow-up. So good amount of follow-up. It's a huge follow-up for prostate. Number needed to prevent 1 death is 8 as per SPCG, which is very good. If you compare that with the previous number of ERSPC, which was 18, if I can just quickly refresh the memory. So number needed to prevent 1 death is 8. So extended follow-up substantially reduced the mortality after prostatectomy, and the number needed to prevent 1 death continued to decrease when the treatment was modified according to the age at the diagnosis and the tumor risk. And yeah, so that was the summary of SPCG. Though the effects are seen after multiple years of follow-up, what sir was saying that in the screening arm, that is what the criticism is, that you need to follow them for very longer duration to actually understand the advantage after certain years of 15 and 16 years. Another similar follow-up of the same SPCG paper, 29 years of follow. What they said, 23 years of follow. What they said was the surgery gives 2.9 years of extra life gained with radical prostatectomy over watchful waiting. So obviously these terms here, though they have used watchful waiting as a terminology, they probably meant surveillance because it wasn't a robust entity as described or a prescribed entity at that point of time. This is what they have done in their papers. So SPCG is in favor of surgery, but that is on a very long-term data. Pivot is a neutral, it doesn't show any advantage of surgery in general. Though obviously you're not going to quote these papers for defining the treatment plans, but these papers are the backbones of decision making, so you should be aware of these papers. Pivot will tell you that at 20 years of follow-up, localized prostate cancer surgery was not associated with significantly lower all-cause or prostate cancer mortality at 20 years. A surprising finding, but it is a finding, though the numbers were little lesser in general. So 364 in general. And Protect is another study which also told us that there is at 10 years of follow-up. This is remind you, this is a study for a screen detected individuals. I just showed you the slide. So in that, at 10 years, prostate cancer specific mortality was low irrespective of the treatment. So it is also not in very much favor of surgery, but surgery and in this paper, there were 3 arms: surgery, radiation, and observation. So one important finding of this paper is surgery and radiation. So either of the definitive therapy reduces the risk of disease progression and metastasis. So metastasis-free survival and disease-free survival are better. OS benefit has not been translated at 10 years, but again, the criticism is it's just a 10 years of data which they have published. Another 5 years they will follow, probably there will be some advantage in OS. So these 3 papers in favor of your definitive treatment that you should say. Probably pivot you may not quote, but SPCG and Protect you should quote for definitive therapy against to the observation. So that slide already we had put it. So this patient obviously will be eligible for surgery versus radiation. A thorough counseling has to happen. How do you justify in the exam which modality you would want to choose? I would answer that question, and then I would ask sir to discuss about the procedure of RP and like few steps for as an exam prototype question. So pre-operative counseling is most important. Both the options are valid for the patient. So never say that this patient will be benefited better with surgery. Examiner may get offended. Both the modalities are parallel. Till date, there is no modality which is proven over each other as a superiority because they are difficult to compare. Their outcomes are completely different. Their follow-up protocols are different. Treatment perspectives are different. So it is highly difficult to compare surgery versus radiation head-to-head in a randomized scenario. Just to quote, a trial called SPCG 15 is currently accruing patients, which will give us results after 10 years. We don't know whether it will actually give us results. So it is yet debatable issue. So never say that my surgery is going to be better than radiation. You can always say that treatment aspects are the treatment perspectives are either surgery or radiation. I will decide based on the fitness of the patient's understanding about the disease, the nature of the disease or the biology, high risk versus intermediate versus localized, the urinary bother of the patient as a baseline. That is very determinant or important factor for you to take that decision. And age of the patient. Younger the patient, you will tend to do a little over, because on surgery, you will always have radiation as a spare modality in terms of adjuvant or salvage. We will come to that as a part of discussion later, but give a perspective to the examiner, and examiner will be happy, in my opinion. That is what I would say, but I'll give that question to sir for quick answer, and sir can quickly take us through the steps of RP. For example,
thank you, Ashwin. Yeah. So I think counseling becomes the most important aspect, because I think examiner would actually not ask much about RP, but counseling is the most important step where they would try to judge the candidate. So there, as you mentioned, if patient has a typical urinary symptoms, or patient has to understand what are the problems associated with surgery in the form of incontinence, and what are the steps they're going to need. So and whether he's surgically fit with respect to anesthesia checkup. So these would be the lines. So in an exam, the candidate has to mention that he would have a MDT discussion in front of the patient, or whatever the protocol in the institute is. But the patient must be sent both to the radiation oncologist and to the surgeon, which is the candidate himself, to explain independently about the problems or benefits, and then the patient has to make a decision of his own. However, examiner would put them that, okay, patient went to radiotherapy, now he's confused, what should I do? Then he can tailor his answer based on, if the patient has predominant urinary symptoms, then probably surgery will be better. Or if the patient is even if a patient is if he undergoes surgery and he develops problems, then the surgically created problems are more finite to manage, and then radiotherapy can always come as a salvage if at all required later. But doing vice versa makes the surgical exercise much more complicated. Now, having said that, radical prostatectomy, how do you do it? I don't think even the residents would be able to answer an open radical prostate. I don't think many might not have seen in their centers. If they have seen radical prostate robotically, they can actually get into the steps and tell it. But typically, what it involves is removing the entire prostate with its capsule, separating it between the bladder and the prostate, because there is no plane there. It's actually anatomical cues based on which you decide between the bladder and the prostate, and then to decide about the nerve preservation. So traditionally, you would identify, once you open, if you're doing an open surgery, preferably it would be an extra peritoneal surgery. You don't have to open the peritoneum while doing open. When you're doing robotic, you actually go transperitoneal most commonly. When you're doing open surgery, it's the bladder neck, which would be the thing which you would identify by pulling the catheter, and you can feel the bladder neck. So you can I define the prostate all around. So drop the bladder, get into the space of Regis, laterally see the endopelvic fascia, inside the endopelvic fascia at its junction with the reflection of the levator ani muscle, and so that it hangs only with the pure prostatic ligaments on either side. And then you clear off all the pre-prostatic fat. Now, this would define the prostate all around clearly. Once you have defined it, then there could be variation in techniques that you might do an antegrade or a retrograde based on whatever you like to answer. But because at one point of time you would have to decide antegrade or retrograde. Take a DVC stitch, and typically the DVC stitch would be taken by facing the head end of the patient, that the surgeon stands on the right hand side, faces the head end of the patient, and then his needle would be would be a 5/8 circle needle, Weichel needle, and it will be facing the curve of the needle would be parallel to the pubic arch. So once you hold the needle, and there are specific needle holders which are an angled curve, so that it aids in passing the through. So once you take the DVC stitch, run it, take another stitch proximal to it, and then cut it in between. This would take away the bleeding part of it. Having done that, we would typically, in an open surgery also, we do retrograde antegrade fashion, that we open the bladder neck, reach the seminal vesicle, lift them up, and then keep on dissecting the. Once you lift the seminal vesicle, if you're doing a nerve preservation, ensure that you would mention that you don't use cautery and you expect a lot of bleeding, because you are cutting through the vessels at many places. But then you can keep on dissecting, putting the clips, so that you already know that lateral to endopelvic fascia, you already incise that, and then between the seminal vesicle and the and the lateral aspect is what you have the neurovascular bundle running. So you will dissect close to the prostatic capsule. So when you explain, you would explain that the neurovascular bundle you are expecting out in between the levator fascia and the prostatic fascia. So if you go a plane below the prostatic fascia, you would do an intrafacial dissection. If you do bit outside the prostatic fascia and between the levator ani, you will do the interfacial. And once you move out of the levator fascia as well, that's it. That is where you're doing an extrafacial dissection. So if you have a lesion on one side, you will always mention that you will do a radical dissection on that side. You will not try to preserve the nerves, so that you do an extrafacial dissection. If you have no lesion on one side, then at least you would save the nerves on one side by going inside the prostatic fascia and teasing that tissue.
Ravi, 1 minute.
Sir,
Are you fixed on the slide only, or you have some other slides coming?
No, we have some other slides coming, sir.
No. This procedure, when you are describing, you are on RP already slide, na? Correct, na?
yes, sir.
Yeah,
yes.
yeah. As he's just describing it as a part of standard steps, sir.
Okay, fine. I was thinking that probably sliders are not moving, and you are.
No.
No, we don't have that pictures to show that. Actually, that should have been included here. We missed the part of that discussion. But then I as I initially said, I don't really think that the examiner would be interested to know the steps of RP.
Steps of it,
but,
right?
Yeah. So they just have to know intrafacial, interfacial, extrafacial, the facial anatomy of the levator fascia, the posterior denominator fascia, and the prostatic fascia. The junction of that is the area where you would have neurovascular bundle running through, and the DVC stitch. These would be the gross steps.
Yeah. So what I would just quickly add to this is pros and cons of each modality. You need to understand very well. That's all theoretical part. Negatives of surgery obviously will be discussed about perioperative complications, the incontinence, and the erectile dysfunction. So you should be knowing which factors are very important for both the aspects. As in, it's a multifactorial event. It's not only one go which decides about the incontinence. So age, the risk quotient of the patient, the biology of the disease, interfacial, extrafacial dissections, volume of the prostate, obesity, diabetes. So these are all factors which are contributing to the continence, as well as your reconstruction, the bladder neck preservation, Rocco stitch or anterior stitch. So just read through all these factors which will help you to give the answer about the incontinence and the erectile dysfunction. So let's go to little theoretical aspects. We would want to keep it more theoretical in the session. Is that okay, sir? Should I go ahead with the
discussion? Yeah, one question in the audio from one of the residents, that how do you decide between RP and RT in a high risk prostate cancer? Like,
so we are coming to that second scenario if we brush up in time.
Yes.
Should we go ahead
Let's
quickly?
move on. Yes, let's move on quickly.
Perfect. So regarding the lymph node dissection, I'll quickly tell. So you should be knowing few nomograms of prostate. So Briganti nomogram and Roke's formula. Sometimes Roke's formula has been asked in the exam scenarios. So they are the ones which tell you about the possibility of lymph node involvement. For purposes of dissection, anything which is intermediate risk. So anything which is intermediate risk and beyond, you will go for lymphadenectomy. As per the NCCN, more than 2% risk of lymph node involvement, you will go for lymphadenectomy. So essentially, majority of the patients will fall into that spectrum. Lymph nodes dissection, as of now, as per systemic review, this is a 2017 European Urology article, no direct survival advantage which has been seen, but it gives distinct advantage in terms of accurate clinical staging and prognostication. So lymph node dissection is a must tool as a part of prostate cancer surgery, especially when the risk of lymph node involvement is higher. So the next slide. Yeah, give me 1 second. So sorry, so I'm not able to see the topmost thing, so I've just had to minimize. So post-operative nomogram for 10-year probability of post-prostatectomy recurrence. So this is another nomogram called Steve. I have kept few slides just to let residents know that few nomograms they should remember. So Stephenson nomogram is one important nomogram which is there in Campbell, which tells you about the possibility of recurrences post-prostatectomy. And it also tells you the possibility of the Epstein and the other nomograms will tell you the predictivity of the pathology of the post-prostatectomy specimen. So that is what the understanding is. So let's come to a scenario of rising PSA post-RP, because if the exam viva goes a little further after this scenario, what will be the ideal goal of a PSA after the prostatectomy? It is less than 0.2 nanograms per ml. Few people will follow 0.1, but majority for exam purposes should be 0.2. Am I right in saying this, sir? For our exams, it's 0.2?
Yes, I mean, for rising PSA, yes, 0.2.
Yeah, so our target PSA should be undetectable or less than 0.2. We do it at about 4 to 6 weeks of post-prostatectomy, the first PSA, and then we essentially follow these patients every 3 monthly for continence as well, continence recovery and the PSA follow. So that is how your standard follow would be for prostate patient. So rising PSA, we know that till now there was. So I'll quickly discuss about adjuvant and salvage scenario, and then we will move on to the high risk case. So adjuvant meaning simple difference between two. There is no confusion at all. Adjuvant means you are destined to give radiation based on the pathology features, high risk pathology features, wherein you are no longer actually going to invariably the PSA will be higher itself, but you are actually not relying based on the PSA. But it's majoritarily the decision is based on your pathological features. So the trial for adjuvant, there were two important trials, one by Thompson and another by Bola. Bola was the important trial. So both the trials told us that adjuvant radiotherapy at long-term follow-up improves the metastasis-free survival as well as overall survival. So this is an important pillar or armamentarium. There were 3 trials which were called Radicals, Raves, and JETUC AFU 17. There is a nice meta-analysis which is published. I'm going to summarize it quickly in favor of salvage. So what do you mean by early salvage? Early salvage means I am not potentially destined to give radiation to all patients based on pathology, but I'm going to follow them up with the PSA follow-up. If the PSA is acceptable less than 0.2 nanograms per ml, I'm not going to intervene at that point of time. The reason being, you're potentially over-treating few individuals if you are supposed to give RT to all based on pathology. So that is what we are trying to avoid in salvage RT, thereby minimizing the toxicity of 2 modalities. So in the meta-analysis, if you actually see, this is an important slide, 33%, 50%, and 54%. And in the total meta-analysis, nearly 40% individuals needed the salvage radiation in the follow-up. So nearly 60% patients did not require actual radiation in the longest follow-up, which was about 6 years, 5 years, and 6 years. So nearly 5 to 6 years of follow-up. So that is what you have to remember. Survivals essentially stayed the same because, like I said, in prostate cancer, 5-year survivals are not very good numbers for helping you to take those decisions. These numbers should be at least beyond 10 years of follow-up. So near 90% event-free survivals on majority of the occasions in all the trials, if I can just quickly give it to you. So what they said was 5-year event-free survival was 88%, 60% did not commence salvage radiation till the median follow-up. Minimal, so early salvage had less of toxicity, or the other way, adjuvant had a lot of grade 2 and beyond GU and GI toxicity. urinary morbidity and erectile dysfunction. So all parameters are going to be negative in terms of toxicity if you think about adjuvant. So probably in a this is the best important line from the AU summary. So at least 2 out of 3 risk factors, if they are there, which is either T3 biology or node the R plus resection, that is margin positivity, or Gleason grade group of 4 or 5. If either of these 2 parameters are there out of 3, then you preferably quote about adjuvant radiation. If only 1 parameter or less than that is present in the high risk features, then you can think about salvage radiation depending upon the first PSA. So the answer in the exam can be, I would see the first PSA and then take a decision whether I'm supposed to give him adjuvant radiation or salvage radiation. If there are no major high risk features, only 1 or 2 high risk features, I would probably do a salvage if the PSA is less than 0.2. If there are more high risk features, or the PSA is just a near 0.2, I would probably think about adjuvant radiation. That is the best way to answer in the examination. One additional point, adjuvant radiation also is generally given at about 3 months. The reason being, you need to have better continence for the patient before you are committing for the radiation. So on an average at about 3 months, once the patient narrows down to 1 single pad or a safety pad, that is a good time to give adjuvant radiation. And salvage, like I said, there is no timeline to it. As long as the PSA is less than 0.2, you're not giving it. If the PSA starts creeping up after 5 years, still you can say that at 5 years, I'm going to give salvage radiation at that point of time. So do you want to add anything about this thing?
No, perfectly covered. I think Ashwin, there are certain questions about Rocco stitch indication, advantage, Regis pairing.
That will take little later because there are many questions. I have made note of that. You can
we'll answer at
so should we in 15 minutes, should we cover a second scenario and then discuss the questions in the end for like 10 minutes?
Yes.
All right. So quick second scenario on locally advanced prostate cancer. So I'll just quickly run through. 64 on the retention, had a lot of LUTs in the background. PSA was 21. Unfortunately, with the catheter, that is another question in the examination. If there is a retention, how long you would want to wait? 4 to 6 weeks, I would say. But if you're utilizing MRI as the armamentarium and the PSA is high and the index of suspicion is higher on the examination, you may not wait that longer. So you can justify what you want to say. Am I right, sir?
Perfect.
Yeah. Okay. So this individual had an MRI done. I had a examination which was suspicious. There was a nodule bilaterally. So went ahead with an MRI rather than just waiting for a PSA fall after antibiotics. Had typically the lesions involving the seminal vesicles. So and catheter in situ. So you should be knowing these. How to read these. So this MRI probably would be kept for you for understanding or reading in the examination. So skipping through the discussion here because we've already covered part of MRI. PSMA PET showed the similar findings, uptake in the seminal vesicles on both sides. Biopsy was Gleason grade group 2 cancers. We forgot about discussion of grade group. So please remember to say grade group in the examinations rather than saying Gleason score now. So that gives you a different score. So decision making in this individual concerns obviously median lobe, thick bladder wall. So again, risk stratification, I would say he is a locally advanced first of all because SV invasive disease, and high risk because PSA was 21. So combination of high risk and a locally advanced disease as my definition on a catheter. So the risk factors were big median lobe, indwelling catheter, thick bladder wall, and locally advanced nature. One thing which is always debatable is about bladder neck invasion. So earlier, this is an important point. Earlier, people used to say that bladder neck invasion is called T4, but it is no longer T4. It is T3A because first of all, it is difficult to make out on investigations, both on radiological and pathological investigations. So as per the AJCC 7th, it is converted to T3A and the prognosis is exactly same as T3 disease. So it is no longer a T4 disease. That is an important note here. So like I said, decision making between surgery and radiation, what I've done is I've given few papers which are of important reference for the discussion of radiation, because for high risk disease, for exam purposes, if there is no pressing indication for surgery, I would still say you should think about radiation in your mind, radiation with hormone therapy in your mind to be safe in examination. That is what my strategy would be. Only in this individual, for example, he was already on a catheter. So there is still an option of prostatectomy versus TURP followed by radiation, which is a debatable option. I'll come to those.
Ashwin, make it full screen, please. Yeah.
Sorry, sir. Yeah.
Thank you.
So, right, sir. So these were the trials of escalated dose radiation. Earlier, they used to give less radiation dose, but for high risk and intermediate risk, they escalated the dose to 74 and 78, and that translates. So this is about the radiation dose. I'm covering 5 minutes of quick discussion on the aspects of radiation. I've put some efforts to gather these data because we are not very much tuned to these data. We just know that radiation is to be given, but we don't know the nuances of it. So 74 and 78 grays are the doses. Generally for high risk, we give 78 grays. That there is a robust data on dose escalation versus conventional dose, the 64 versus 74 data and 68 versus 78 data. Dutch trial, MRC trial, and MD Anderson study, and it translated into both OS advantage as well as disease failure-free survival advantage. The addition of hormone is another question which is always discussed. For intermediate risk, we generally say for until 1 year we give it at least. For high risk, we generally give it until 2.5 to 3 years. So there is a data on long-term use of androgen. It's a paper, it's a Lancet Oncology paper, a paper to be quoted in examinations, a paper given by Bola, and it's an EORTC article. So, so that tells you that I'll read the summary here. In patients with prostate cancer with high-risk metastatic, immediate androgen suppression with LHRH agonist during and for 3 years of external radiation improves 10-year disease-free and overall survival both, without any excess late cardiovascular toxicity. So for high risk, for theoretical purposes, 3 years, but you should give it at least for 2.5 years and discuss about that. So that is an important question. So radiation with hormone in high risk, 2 years and beyond, intermediate at least for 1 year. The similar paper from Bola, which told us that 6 months of radiation is inferior, 6 months of hormone is inferior to 3 years for survival advantage. So you can quote this paper when you are backing your answer of 3 years, or you may not say 3 years. Majority of us have now turned to 2 years. Sir, am I right in saying this?
Yes. So 18 months to 3 years would be a good approach to say.
Yeah, you can give a range and say when you're quoting a paper, you should quote this particular paper by Bola et al. As an RTOG and EORTC group. Another important paper of pelvis only versus pelvis plus prostate RT. So POP RT was our own trial from Tata Memorial. So that will tell you about the importance of giving radiation to the pelvis for high-risk prostate cancer, high-risk and locally advanced prostate cancer. So that is an important trial which you should be knowing. So probably you may not go to the all core nuances, but just remember the name and the important finding out of the paper. And a data on hypo fractionation. Before that, what I will I'll tell you the difference between the 3 types of radiations. So first is most importantly, initially it was a conventional radiation which they used to give. The dose used to be given from 1 or 2 sites, either from below or above. Potentially the toxicity was higher because any dose coming from below or above is going to have 50% dose escalation to the collateral area. That's why they came up with the idea of 3D CRT, meaning you're giving dose from 3 to 4 locations, so that those collateral toxicities which are going to be 50% will be divided still further, will be like 11% on whichever side, because the dose of the radiation beam is going to be coming from different aspects, or 3 or 4 aspects. That was 3-dimensional 3D CRT. The next is IMRT and IGRT. So intensity modulated radiation therapy and image guided radiation therapy. So image guided essentially is a part of IMRT. So they are not separate. IGRT itself can be called as image guided intensity modulated radiotherapy. What do you mean by intensity modulated radiotherapy? The number of sites from which the dose is going to be coming to the target organ is going to be increasing, thereby minimizing the side effect. Simultaneously, you are going to conform the organ. So you are going to form a target area around the organ in a 3-dimensional space that would minimize the dose given to the collateral. That is called as IMRT and IGRT. Image guided is on the routine occasions, you are going to do the imaging now and then for the patient, so that you ensure that the prostate is still exactly located there. There are no changes because of the bladder inflation or the bowel distension. So that is what we are looking at. That is called as image guided radiation. It's a type of IMRT. Difference between 3D CRT and IMRT, the number of sites from which the dose is coming is changed. The number of sites has increased to 7 or 8. That's why they are minimizing the side effects, and there is a conformal shape around the organ which is formed. And the last part of it is called as VMAT or rapid arc technology. It's the same modality as of IMRT. Only thing is, in IMRT there are 7-8 locations from which the beam is coming. Between one location to other location, there is no radiation which is given. In VMAT, the same thing has been done, but when the beam changes from one location to the other location, the dose is still continued, thereby minimizing the on-couch time and hence possibilities of toxicity because of patient movements and other toxicities. So that is called as VMAT and 3D CRT. The rapid arc technology. So only 4 or 5 terms which you should be remembering. I'm just quickly enumerating those in the order of preference or order of betterment. Conventional radiation, 3D CRT, IMRT and IGRT combination, and then the last is VMAT or rapid arc technology. So that is how the radiation works. We discussed about the total dose escalation of the radiation. We discussed about the hormone requirement along with the radiation and quoted the paper. So you should go through those papers. The last thing is now the recent technology is hypofractionation. So what do you mean by hypofractionation? Conventionally, the dose given, for example, if you're giving 78 grays, you divide it into 39 fractions. So you will give it 5 days a week into those 39 days. So that will be like roughly whatever, 7 weeks or 7.5 weeks of treatment. That is called as conventional radiation. Anything which is beyond 2.2 gray, gray is the unit of these dosages. Anything which is beyond 2.2 gray will be called as hypofractionation. So now if it is called as mild hypofractionation if the dose given per one cycle is between 2.2 to 3.5. Between 3.5 to 5 it is moderate, and beyond 5 it is called as ultrafractionation. So you should just remember that in low risk and intermediate risk prostate cancers, radiation departments are utilizing now hypofraction modalities, though it is proven under randomized trial circumstances as a definitive rule, though it is not assimilated to the core. But ultrafractionation and hypofractionation has been tried as per the CHIP trial and certain other trials also. So that is what I would say for the radiation. Last 3 slides I have, then we will keep it for open for discussion. So answering the question of the individual who asked about the treatment strategies for high-risk prostate cancer, what I would say, look into the case. If there is any pressing indication for prostate surgical intervention, for example, the case which we discussed, he was on a catheter, so he needed one surgical intervention for prostate for sure. If you're confident in saying this or quoting this in the examination, you can say that prostatectomy is the choice. If you feel that is going to be a potential problem for you, you can still stick to TORP followed by radiation and hormone. But you will start hormone well in time, do the TORP, get the patient catheter free, and give radiation at about 3 to 4 months of TORP. Multimodality is been discussed as of now, not under randomized trial circumstances. There is a role of prostatectomy and as far as the multimodality management goes, which translates into cancer specific survival as well as little amount of overall survival. But again, it's all retrospective data on a large cohort of patients. Only few papers which are here. The advantage is as per few papers, OS and DSS advantage with respect to so it is multimodality, meaning surgery followed by radiation. So that will have advantage over RP versus RT plus HT versus RP. But again, retrospective data, there will be reservation in quoting this in the examination. So you probably can take it with a pinch of salt when you are quoting it. If you're uncomfortable, please stick to TORP followed by radiation and hormone. RP with adjunct RT is a better modality in LAPC and high side effects of ED. So side effect profile is going to be more because you are already committed for 2 treatments potentially. Again, the similar paper which translates into OS and disease specific survival advantage on a large data set of SEER population, but a retrospective data. So what advantage you are going to get out of multimodality? So this is an important thing which we can quote in the examination when you are justifying prostatectomy. Like I said, I will say in exam purposes, in my routine practice, probably I'll go for prostatectomy in high-risk patients also, but that is not the way to answer the exam. In examination, I would probably say if there is a pressing indication, for example, patient is miserably bothered by LUTS, he's getting up 7-8 times in the night time, or he has some cardiac elements when he is a potential problem patient for hormone therapy for 2-3 years, or he has an issue for he is already on a catheter, then I will, or there is direct contraindication for radiation in terms of having previous small bowel disease, Crohn's, anything of that sort, then I will potentially think about prostatectomy in this particular individual. The advantage is volume reduction, optimal local control, more accurate pathological staging, because here you will have the entire representation. All T3s based on the clinical imaging may not turn out to be pathologically T3. So there can be a downstaging on the pathology. So accurate risk stratification, accurate pathological assessment of tumor characteristics. You know how the PSA is going to dip after the surgery, and it will better select the patients for the subsequent therapies. I'm not going in oligometastatic scenario. Just to quote, there are good number of trials in oligometastatic scenario which are accruing patients for surgery, and there is a randomized one evidence on Stampede arm for the HORAD was not a very productive trial, but Stampede radiation trial told us that oligometastatic setting, prostate native prostate should be treated with pelvis for oligometastatic scenario also. And this was the trial which I quoted, a direct comparison between two arms, but we do not have answer to this. So I'll stop here. I'll ask sir to give inputs, and then we'll discuss question answers maybe.
I think Ashwin will go to straight away question answer because that
Sorry,
will
yeah.
be able to cover up. Yeah.
Right.
Sir, you can.
I think they can switch on the mics and ask directly if that is okay. Sir,
Ravi?
do you agree on this?
Sir,
Ravi, are you
Sir?
okay? Now, are both of you ready for the questions?
Yes,
Yes,
sir,
sir,
we
yes,
can
sir,
hang
we
around
should
for
be.
some time.
Yeah. So the one question is from this is from Gurpremji. Based on the risk stratification, how to say which is better, radical prostatectomy or radiation therapy? And what is the advantage of each based on the risks? That is the question from Gurpremji. I think you have covered it, but if you can make it a little more clear to him so that we
Sir,
come
you
to
want
the
to go ahead?
Yeah. In exam, if we just want to stick to that, then in exam, if it's a high risk prostate cancer, you will never say that it is one is better over the other. You will always have to say that both options are to be explained to the patient. Both options will be equally oncologically, both are equally acceptable, or they score with each other. But then, as we discussed, that if the patient has anything which requires, let's say he's on a catheter, he's got severe LUTS, or he's got, I mean, he's so. If you tailor your answer saying that surgery would be preferred in a situation where patient has more local symptoms than radiotherapy, or based on your examination or imaging finding, if you say that if the disease seems to be locally advanced, so high risk prostate cancer and locally advanced would be two different categories. So high risk may qualify for both, but for locally advanced, you might actually say that I would go with ADT and radiotherapy because there the chances that I might leave some disease inside are higher. Having said that, in the last section of the discussion, we did cover that even in a locally advanced high-risk prostate cancer, you could offer a radical prostatectomy, especially in a situation where patient is having significant local symptoms, so that you take care of it. And then as a part of multimodality treatment, when you add radiotherapy and hormonal treatment, they still fare better. But in all the entire scenario, your expectancy beyond 10 years should become the key for justification. Yeah, Ashwin.
So what I would say is in exam, I'll try and play safe. Locally advanced scenario, examiners also probably may not be on the same page of prostatectomy. So if there is no pressing indication, or even if there is a pressing indication, like for this particular individual, it can be a safer approach if you say TURP followed by radiation and hormones. You will not be harmed by saying that. If you say prostatectomy in a very locally advanced scenario, probably there will be a challenge for that particular answer. So be safe in the exam. Just go with the flow. Understand what the examiners the body languages, and just go with it.
Yeah, I'll come to the next question. This question is from Ravi Mishra. He has asked about Regis sparing radical prostatectomy advantage, and probably the question next is minimum number of lymph nodes, and what are the boundaries of extended lymph node dissection, and indication of Rockford stitch. Yes, this is basically on the surgical management, the radical prostatectomy.
All the four questions. So Ashwin, maybe you can take first two. I'll answer the rest of it.
So I missed out on the question. I'm sorry. Okay.
So the question is, what is the advantage of Regis sparing? So
yeah. So Regis sparing will
sparing
have, as of now, under few randomized trials, but those are limited numbers. Only early continence improves. Early continence meaning initial 3 months continence, but after 6 months it neutralizes. It becomes equal. So I don't think that in exam scenarios you should be uttering a word of Regis sparing prostatectomy.
Absolutely.
Stick to what you have seen or you have probably read about it. Do not utter a word of Regis sparing prostatectomy. More fancy stuff you would want to go for, you will be in more trouble.
Correct. So whatever you say, you must know the head and tail of it, then you would be able to justify it. And as Dr. Ashwin mentioned, if suppose examiner directly asks you what is the advantage, then you can say that early continence, but it comes at a cost of higher risk of positive surgical margins. So both have been reported in the literature. Just stick to this, that Regis sparing has early higher continence, better continence. At the later end, it will be same. and this comes at a risk of higher positive surgical margins. Now, Rocco Stitch, literature wise, yes and no. There are papers where they would say that Rocco Stitch provides good support and continence. But however, even if you don't do Rocco Stitch, there are papers where they say that there is no difference in with respect to continence. In a clinical practice, if the distance between the anastomo, if the distance between the bladder neck and the urethra is way away from each other, that is, you are operating on a larger prostate, that is where you do a Rocco Stitch rather than doing it in even a smaller prostate. Ashwin?
Yes, sir.
Yeah.
So regarding lymph nodes, I'm not sure, Ashwin, what is the
No
exact
number for
of
prostate
nodes?
at least. No number
I'm
described
also
for
not
prostate.
aware
Yeah.
for prostate because
Extent
lymph
wise,
node
we generally
traditionally
try and stay medial to the artery and the external iliac artery. So we take a template between the external iliac artery, external iliac vein, and obturator. Extended template lymph node dissection in a prostate means whether you go cranial and caudal to the obturator nerve. It doesn't mean the extent as similar to what we discuss in bladder for common iliac nodes. It's always the iliac group of nodes, external iliac group of nodes, and obturator group of nodes, and cranial and caudal to the obturator nerve. That template is more important for prostates.
Yeah, I'll come to the next question. It is Gurpremji again. He wants to ask whether PSMA PET-CT is in the guideline of localized and locally advanced. We have already described.
So we answered yes, sir.
Again, yeah, again you can make it little.
Yeah, so PSMA as of now,
go
it is assimilated in the AU guidelines. Sir also agreed on that point. So it's safe to quote it in the examination in 2022. But alternative will be not only bone scan with CT of the abdomen, because only bone scan will be an incomplete workup.
The next question is from Anshuman. He wants to know that adjuvant radiation therapy for positive surgical margin after the radical prostatectomy.
So like I said, I will, if there is a positive surgical margin, there were three things mentioned: positive surgical margin, Gleason of 4, grade group of 4 or 5, and T3 disease plus. So anything which is T3 and plus, which includes N plus disease also, obviously. So anything, 2 factors out of these 2, I would go for adjuvant radiation. But for exam purposes, still a salvage radiation is not a very robust modality assimilated by everyone. So for exam purposes, what you can say is, I'll wait for first PSA at 4 weeks or 6 weeks, see the PSA dip in because of the effect of surgery, and then take a decision whether I would want to give radiation as an adjuvant or monitor the salvage. If the PSA dip is significant, if the first PSA is less than 0.2 to a very large extent, I know that probably his chance of requiring immediate radiation is less. I'm happy to put that patient on salvage. Exam scenario wise, the number of locations of margin positivity also can be considered as potential point between adjuvant versus salvage. If it is unifocal, also try and get a comment from the examiner. It's good to ask the examiner about this. Sir, can I know about the score at the margin also? So if the score at the margin, Gleason score at the margin is say 3+3, that tells me that it is like a favorable biology disease, or even Gleason 3+4. But against to that, if it is high risk at the score of the biopsy, the margin, I would be on a side of adjuvant. Or if it is multifocal, I would be on a side of adjuvant. But again, like I said, there is a good backing now in AU after the randomized trials of salvage. To at least 2 out of these 3 risk factors, go for adjuvant. Otherwise, you can still think about salvage. So as long as you justify what you're saying, examiner should not be unhappy, as far as my understanding goes.
Absolutely.
So there are last two questions is what should be the criteria for oligometastasis? Will it be chartered or glass or anything according to you? And last question from Naman: any role of focal ablative therapy for the low risk disease?
So focal ablative therapy, I would say just keep that theoretical. Let's not put it as a part of exam scenario. You should read about HIFU. You should read about the cryoablation and the failure, definitions of failure after that, similar to what we do for post surgery or post radiation. We didn't discuss about post RT failure, sir. Do you want to quickly cover those Phoenix and Astra for them to understand?
The time.
Astro and Phoenix criteria for the post RT failure.
Yeah, go ahead, Ashwin.
So the earlier criteria used to be you follow it up serially and there will be two rises, and then you will take it from the midway through the rise point. That was astro, right? Sorry, I'm just forgetting my definition. Sorry, I may be mistaken, but that was an astro definition.
Yeah.
And phoenix is one single rise of 2 nanograms per ml above the baseline nadir levels is phoenix. You prevent backdating in that so that you don't waste time. And now we follow phoenix criteria, not the astro criteria. So read about these two. These are favorite theoretical exam questions for the examiners. Another exam question is only purely because of the radiation effect, how long it will take to have the PSA down. Radiation acts on a basis of apoptosis, so it doesn't have immediate impact. Only radiation will take good 9 months to a year or so for PSA to dip down. That's why you add hormone along with it, so as to have a shrinkage of the prostate as well as to have a PSA dip in the treatment follow. So do you want to say about the definition of this thing? Chartered. So this oligometastatic, I probably would say Chartered will not give you a definition of oligomet. Chartered will give you the definition of high risk disease, high risk versus low risk disease. The oligomet is it's a universal definition. Few people have said beyond 3, or certain people have said, or up to 3, or certain people have said up to 5 bony metastasis. No visceral metastasis, and yeah, that's it.
Yeah.
The final question is from Ravi. After that, we'll close. That is indication of monotherapy or only ADT in high risk localized CA prostate. Some sort of any indication, or is there any evidence for that?
So do you want to say this?
Only androgen deprivation therapy for high risk localized CA prostate.
So whenever you are adding radiotherapy with ADT, the idea is with curative intent. Again, if the intent is curative, then you would actually do a radical radiotherapy with ADT. However, if the intent is not curative, the only ADT, I think all the guidelines would actually restrict there because ADT has its own side effects, and you also know that they're going to develop androgen and hormone resistant eventually. So only ADT probably nobody will justify as a part of guideline. Ashwin?
It should be brought into the any sort of answer also. It shouldn't be an option to be entertained at all. You should not bring this into your answer. So I think we'll close this the question answer section.
Can I have 2-3 minutes if that is feasible, sir? Just to tell them about the difference between surgery and radiation. That will also have some repercussions for their clinical practice eventually also, if I make in quick 2 to 3 minutes discussion between surgery and the radiation when we compare those modalities for pros and cons. Can I just quickly do that, sir?
Please go ahead.
Yeah, so I'm just going to be quickly summarizing points. Surgery, you will have advantages of surgery on one side and mirror image, which will be a kind of disadvantage of radiation, and vice versa. Whatever are the disadvantages of surgery will be the advantages of radiation later on. So I'm going to enumerate this advantage of surgery first. Why I'm saying this is because that can help you to code in the examination about your treatment plan and justify that in treatment plan, and probably further once you pass exam, it just being there, after that you're going to be clinicians, so that will help you to take some certain decisions also. So surgery, you will have pathological stage because there can be underrepresentation, downstaging or upstaging both. On the radiation side, it is always clinical stage, so there can be a minor element of error. So that's the first difference. Second difference, my surgery will tell you about the effect of PSA dip. So that is going to exactly repercuss on the PSA implications. And PSA will, as the prostate is out of the body, PSA is going to be an ultra sensitive marker for the follow-up. So any rise of PSA beyond 0.2 will be called as a definition of failure in surgery, against to a rise of beyond 2 nanograms per ml will be called as a definition of failure on the radiation. So a hell lot of a difference. That's the second difference. Third difference, after the surgery, if my PSA starts rising, I have radiation in my umbrella as a treatment modality. Vice versa, though feasible, generally not a favorable option because of a lot of complications on salvage prostatectomy. So that's the third difference. Fourth difference, someone who has a terrible LUTS and outlet obstruction, prostatectomy is better choice because radiation will get that prostate more fibrous. So he's not going to do well after the radiation, even if you give hormones before and after. That's fourth. Fifth difference, local control. This is an important, and this is the treatment. This is a aspect which has been now boosted for oligometastatic or locally advanced scenarios of as a part of multimodality. Though not a classical exam scenario, but just for your understanding, local control means once the disease is under control, if the disease comes back later after say 10 years, patient does well for 10 years and it comes back, it will also form cancer related problems and local problems of prostate being physically there on the radiation side. It is either going to have obstructions of the ureters or hematuриas or outlet obstruction and catheters, etc. It is not going to happen on the surgery sides. After the surgery, if the disease comes back, it is not going to be in the form of physical form. It's more microscopic or the distant disease, which is going to be forming, not leading to any. So local symptoms are going to be better. So that's the 6th difference. 7th difference, for someone who has potential problems of hormone therapy, on surgery side, not many individuals need hormone therapy. Selective indications of hormone on the surgery side, though they are not well described as a part of guidelines, but in clinical practice, what we follow, if the existing PSA is very, very high to begin with, that is one. Secondly, if there are more than or equal to 2 nodes as per the guidelines, but normally what we follow is even 1 node which is positive, we give hormones to these individuals. So very select group of patients on surgery side would actually need hormone, thereby minimizing those potential head to toe side effects of hormones, including cardiac risk or cholesterol worsenings or diabetes worsening, bone loss, etc. On radiation side, for high risk disease, at least 2 to 3 years, all patients would be at stake of hormone. It is going to be a detriment. So that's the 7th difference. 8th difference, which is an advantage of surgery, potential long collateral damage. So surgery, if everything goes well, no injuries, no problems happen during the surgery, which is a standard norm for prostatectomy, no long-term repercussions on the collateral damage. On the radiation side, there will be some collateral damage as a long-term repercussions. 9th difference, that's the last 9th difference on the 9th advantage of surgery, is potential second carcinogenesis. Though the carcinogenesis after radiation is less, and it happens over a long-term duration of 10 to 15 years, there is a 1 to 2% chance. It's a paper from SEER database which tells us that increased chance of bladder cancers after prostate radiation. It happens over long term, but I would think 10 times for giving radiation in a younger patient because of that. So younger patient needs to be counseled about these aspects also. So these were the 9 or 10 advantages of surgery over the radiation. Disadvantages, obviously the surgical exercise, anesthesia risk, complications of surgery, potential incontinence, and ED. But ED again is equal on both sides, because they're on hormones. Patient is already going to be on ED or for at least for 2 to 3 years as long as he's on hormones. And here, because of the effect of surgery in a non-nerve sparing scenario, he'll be having ED. So these are some disadvantages and advantages of surgery if you just want to go through that.
One more advantage of
Yes, sir.
surgery would be that the complications which are created of surgery are finite and defined. I mean,
Yes.
if you have incontinence because of sphincteric dysfunction, they can be managed very well at the end of 1 year with either a tape or a artificial sphincter based on the level of incontinence, which is a defined pathway. But if you have an incontinence after radiotherapy, it could be multifactorial. It could be because of the bladder, it could be because of the prostate, it could be because of sphincter. So the treatment options, they don't work as predictive as when they work for surgery. So that is another advantage, I would say.
Thank you. I think with this time on behalf of Indian School of Urology and USI, propose vote of thanks to our faculty who are faculty for you, for me. They are my board members of Indian School of Urology. A very, very keen interest in urology you would have seen. It's a testimony to the passion which they have in teaching you all. I think this evening was packed with excellent high quality case discussion, backed with very, very high quality evidence. And I think that has made the day, I think for me at least, and probably all of you. I request you again, when this 2-3 days after it will be online on the YouTube, our USA TV and the USA Smart Learning YouTube platform. Just go in again, because every slide was very, very informative. And I think if you see it again and again, you need not go to the Campbell. You see, you have to read so many pages to learn all this thing in 1.5 hours. They have done an excellent job. Thank you again, Ravi. Thank you again.
Thank you, sir.
Thank you, all the regents who have stayed. Thank you, other members too. And my request to all the regents, please, if you feel you have any topic in your mind or any theme in your mind which you need to be taken up for the discussion for the Smart Learning program, please write to me. we'll take this into our upcoming webinars. And thanks to Navneet and Kiran for the logistic support. Thank you. Have a good day.
Thank you, sir. We
Thank you,
must
sir.
congratulate efforts from Arun Chala, sir. So he's the one
Yes.
who is backbone for this these things. He is the one who is nagging everyone of us to actually come out and pull out time for teaching activities, and we enjoy this. Thank you so much, sir. Appreciate it.
And also special thanks to Ashwin for preparing this wonderful slides, Ashwin. Thank you. Thank you, sir. Thank you, Ashwin.
Thank you.
Good night,
Thank you.
sir. Good night.
We'll have this duo again for many urology sessions.
We will do, sir.
Thank you, sir. Bye bye.
Bye, sir. Good night.
Bye. Good night. Good night, sir.